Hello and welcome to ClinMed Compass. I am Dr. Emoriken, and in today's quick fact session, we'll take a focused look at hypokalemia, an important and potentially life-threatening electrolyte disorder. By the end of this lecture, you should be able to define hypokalemia clearly, identify its main causes, recognize typical clinical features, interpret ECG changes, and understand how to manage it effectively. Hypokalemia is defined as serum potassium of less than 3.5 millimoles per liter. The normal serum potassium is from 3.5 to 5.5 millimoles per liter. We classify it based on severity. Mild hypokalemia 3.0 to 3.4 millimoles per liter. Moderate hypokalemia 2.5 to 2.9 millimoles per liter. Severe hypokalemia less than 2.5 millimoles per liter. Severe hypokalemia can cause life-threatening arrhythmias and even muscle paralysis. As a way of recap, 98% of the total body's potassium is intracellular. This is maintained by sodium-potassium ATP pump. Potassium is vital for neuromuscular excitability, cardiac rhythm, maintaining cell membrane potential, acid-base balance, and the renal concentrating ability. Now we'll look at the causes of hypokalemia. We'll start with potassium loss. Potassium can be lost from the body via the kidneys as well as the gastrointestinal tract. So we'll start with the renal loss of potassium. Common causes include diuretics like thiazide diuretics and loop diuretics, primary hyperaldosteronism, Cushing's syndrome, renal tubular acidosis type 1 and 2, magnesium deficiency, Guttama and Bartter syndrome, and drugs like amphotericin B and high-dose penicillin. All these contribute to the renal loss of potassium. Now we'll look at the extrarenal loss of potassium through the gastrointestinal tract. Common GI causes include vomiting and nasogastric suctioning, diarrhea, laxative abuse, pyloric stenosis, rectal villus adenoma, and intestinal fistulas. Hypokalemia can arise through transcellular shifts. Potassium can shift into the cells in situations like insulin administration, as in DKA treatment, beta-adrenergic agonists, salbutamol, terbutaline, metabolic alkalosis, hypokalemic periodic paralysis, refeeding syndrome, use of theophylline, and barium poisoning. All these contribute to the transcellular shift of potassium. Hypokalemia can occur through decreased potassium intake. This is rare, but can occur in severe malnutrition, chronic alcoholism, prolonged fasting or starvation, and anorexia nervosa cases. Now, we want to look at the effect of hypokalemia in the various body organ systems. First, we look at the cardiac effects. Low potassium lowers the resting membrane potential, which increases the risk of arrhythmias like ventricular tachycardia and ventricular fibrillation. Second is the neuromuscular effects. Low potassium impairs membrane depolarization. This results in neuromuscular symptoms like fatigue, muscle cramps, weakness, and even paralysis. In the kidneys, hypokalemia impairs the ability to concentrate urine. This may cause nephrogenic diabetes insipidus, resulting in symptoms like polyuria and dehydration. Now we'll look at the clinical manifestations of hypokalemia. It is important to state that symptoms usually appear when potassium dropped below 3 millimoles per liter. We look at the neuromuscular symptoms, ranges from muscle weakness, muscle cramps, flaccid paralysis, tetany, which may result in rhabdomyolysis, and hyporeflexia. The gastrointestinal features include constipation and ileus. Renal features include polyuria, polydipsia, nephrogenic diabetes insipidus, and metabolic alkalosis, which arises from increased ammonium production. In the cardiovascular system, we have palpitations and arrhythmias such as ventricular fibrillation and tachycardia, and may even have torsade de pointe. Cardiac arrest is not left out, which is due to arrhythmias. The clinical features of hypokalemia can be outlined based on the severity, from mild, moderate, and severe hypokalemia with their respective features. In mild hypokalemia, they are often asymptomatic, but symptoms like fatigue, muscle weakness may occur. In moderate hypokalemia, we have generalized weakness, muscle cramps, hyporeflexia, polyuria, polydipsia, as well as metabolic alkalosis. In severe hypokalemia, we may have flaccid paralysis, respiratory muscle weakness, tetany, rhabdomyolysis, paralytic ileus, marked metabolic alkalosis, and more prominent polyuria and nocturia. At this level, we begin to have ECG changes of arrhythmia, such as ventricular tachycardia and ventricular fibrillation. Clinical manifestations usually worsen with declining potassium level, as you can see. Severe cases need urgent attention due to the risk of respiratory failure and arrhythmias. Now let's look at the ECG changes in hypokalemia. Important ECG findings include flattened or inverted T waves, prominent U waves, which are best seen in V2 to V4. The U wave is the positive deflection after T wave. You have ST segment depression, prolonged QT interval, possible ventricular arrhythmias like ventricular tachycardia, fibrillation, and torsade de pointe. It is important to state that the apparent prolonged QT interval is actually the QU interval with an absent T waves. This is an ECG tracing that showed the U wave, this positive deflection after the T wave. So you see the U wave here, then you see the T wave, which is inverted, and the ST segment, which is depressed. So in this tracing, we found the prominent U wave, the T wave, which is inverted, and the ST depression. And these are actually classic findings of hypokalemia. This tracing is the same as the previous. This is the U wave, the inverted T wave, the ST segment depression. But what we are outlining here is the interval, QU interval. This is the Q wave, and this is the U wave. So the interval is the QU interval. Now, this slide shows ST segment depression and prominent U waves in some of the leads. You see this circle, the red circle shows us some of the changes in the ECG. If you look at this very particular one in V4, you see the prominent U wave and the inverted T wave, as well as the depression of the ST segment. This is the same thing here, and all others that are indicated by the circle. You see it is widespread. These are classic features of hypokalemia. So it's a slide that shows us the ST segment depression, the inverted T wave, and the U waves. This tracing is showing us torsade the point. You look at the ECG changes here. Torsade the point, it's actually French word for twisting of the points. It's actually a rapid and irregular reading originating from the ventricles. On ECG, like you see, they look like QRS complexes that are twisting around the baseline. Diagnostic approach. First is to confirm hypokalemia. Serum potassium less than 3.5 millimoles per liter. If need be, this can be repeated to rule out lab errors. You do ECG, especially if the potassium level is less than 2.5 millimoles per liter or the patient is symptomatic. You check urinary potassium excretion. This helps to differentiate between extrarenal loss and renal loss of potassium. If the urinary potassium is less than 20 to 30 millimoles per day, it suggests extrarenal loss. If it is greater than 20 to 30 millimoles per day, it suggests renal loss. The blood pressure is also helpful. If you have hypokalemia in the presence of hypertension, you should think of hyperaldosteronism, Cushing syndrome as the cause. If you have hypokalemia in the presence of pneumotension, think of diuretics, vomiting, or renal tubular acidosis. Arterial blood gases helps to check for acid-base disturbance. Metabolic alkalosis suggests vomiting and diuretics as the cause of hypokalemia. Check magnesium. Hypomagnesemia worsens hypokalemia and makes it resistant to treatment. You also consider serum aldosterone-renin ratio for primary hyperaldosteronism, that is Cushing syndrome. Thyroid function test also considered in thyrotoxic periodic paralysis. Let's take a look at the management of hypokalemia. One of the principles is to treat the underlying cause. You identify and treat the cause. This means stopping offending drugs and managing conditions like DKA, vomiting, diarrhea, and other causes of hypokalemia. Another principle is to replace potassium. In mild to moderate cases, oral replacement of potassium is enough. You use slow-release potassium chloride tablets. Alternatively, potassium citrate can be used at a dose of 40 to 60 millimoles per day in divided doses. This is appropriate in mild to moderate cases when there is no significant ECG changes or no symptom. Intravenous replacement of potassium is for severe or symptomatic cases. Administer potassium slowly and never give as a bolus. Do not exceed 10 to 20 millimoles per hour via peripheral line. If you want to give higher concentrations, it will require a central line and ECG monitoring. And do not exceed 40 millimoles per liter concentration per infusion. Next principle is to correct magnesium deficiency. Always assess and correct coexisting hypomagnesemia. Potassium correction may be ineffective without magnesium replacement. To replace magnesium sulfate intravenously is given. Few key points to note in the management of hypokalemia. Continuous ECG monitoring is mandatory if giving intravenous potassium chloride. You monitor serum potassium 4 to 6 hourly. You also monitor the renal function and the fluid status of the patient. Avoid rebound hyperkalemia by going slowly. Briefly on hypokalemic periodic paralysis. This is a sudden, reversible, intermittent muscle weakness due to potassium shift into the cell. During attacks, serum potassium is low, but normal between episodes. Key features include flaccid muscle weakness that may last up to 72 hours, typically affecting the proximal muscles of the lower limb than the upper limb. It's often triggered by rest after exercise, high carb diets, or stress. Hypokalemic periodic paralysis could be genetic or secondary. Secondary, that's the thyrotoxic periodic paralysis. Treatment includes slow potassium replacement, oral or parenteral as the case may be. Prevent recurrence by avoiding triggers. Low carb diet and acetazolamide may help to prevent attacks. Quick facts to remember about hypokalemia. Remember that hypokalemia is serum potassium less than 3.5 millimoles per liter. If it is less than 2.5 millimoles per liter, it indicates a medical emergency. Hypokalemia plus alkalosis with a low blood pressure, you suspect diuretics as the cause. Hypokalemia with alkalosis with hypertension, you think of hyperaldosteronism as the cause. Always check magnesium in resistant hypokalemia. High urine potassium indicates renal loss. And persistent hypokalemia, think something genetic, Liddle syndrome, Bartter, and Guytemer syndrome. Rapid IV potassium can cause fatal arrhythmia. Therefore, when treating hypokalemia, go slow. Never give IV bolus. Now, to conclude this short piece, hypokalemia is a common electrolyte disorder with potentially life-threatening consequences. ECG monitoring is key. Always investigate and address the underlying cause to prevent recurrence. Be very cautious with parenteral potassium replacement. The key is to administer slowly and monitor closely. Always correct magnesium and search for underlying cause. Remember, the principles of management include treatment of the underlying cause, potassium replacement, and correcting hypomagnesemia. Thank you for joining me in this comprehensive quick fact section on hypokalemia. Do not forget to like, share this video, and subscribe to this channel. Hit the notification bell so that you always stay updated as soon as new videos come up. This is ClinMed Compass, your path to medical excellence. See you in the next video.